First of all, we register our gratitude for being given this opportunity to present on our experiences in MAMI, and we look forward to an engaging conversation for the next 1 hour. Next slide. So just overview of our IRC Kenya nutrition program. We work in the refugee context and the non-refugee context. In the refugee context, we are in Hagadera and Kakuma, where Sharon and Vincent, our nutrition managers with allied staff. So in the refugee context, we are offering, or we are providing services, health and nutrition services in level 1 to level 4. So for level 1 is community health services, where we have the community health strategy being implemented. And then level 2 is the primary health care, and the 4 is the referral, where we have our hospitals, where we have inpatient care for the sick. So in the camps, we have PHC, we have the reproductive, maternal health services. We also have mental health and psychosocial support. Definitely have EPI for immunization and also management of non-communicable diseases. So in Kakuma, we are running 7 health facilities, and 2 of those health facilities have maternity wards with average skilled deliveries of about 300 live births per month. And we also have a 36-bed capacity stabilization center. In Hagadera, we have 1 level 4 facility, and in total, we are running 3 facilities. And in the maternity there, we have an average of 265 live births per month. And we also have a 30-bed capacity stabilization center. So it's quite a busy operation in the 2 refugee context. In the non-refugee context, this is mainly through a health system support approach, where we are working in the non-refugee context in Turkana, where we do integrated outreaches, and then in West Pokot, where we are supporting imam services through a technical advisory approach. Next slide. So the first question, I think, which is very interesting, which is very integral in terms of implementation of MAMI, for us within the Kenyan context, we asked ourselves, why MAMI for IRC Kenya? And we saw through our operations, we had very high incidence of preterm children, and those figures show, 2024 proportions for Hagadera operation and Kakuma. So you can see that in Kakuma, we are seeing quite a high number of children who are preemies, 12.5%. Then we also have high-low birth weights, where 2024 data is showing 6.2 in Hagadera and then 15.4% in Kakuma. Then we also seen considerable caseloads of under 6 months who are needing management in the stabilization centers, and also these also compounds to also high mortalities of those under 6 months within our stabilization centers. So necessitating us to have, concerted effort for these cohort. Then, in addition, we also have been able to record high rates of neonatal mortalities within our operations. That 1.9% is from Hagadera. And then critically, we're also seeing a very high burden of malnutrition and anemia in pregnancy from our TSFPs, that's the targeted supplementary feeding programs, as well as from our ANC data. And then finally, we also were able to document gaps in tracking early initiation of breastfeeding at the maternities. Despite having, quite a robust health system, we are not able to, the nutrition is not able to really support in terms of early initiation of breastfeeding and tracking these at the maternities, and also supporting exclusive breastfeeding. Next slide. So in 2023, a decision was made to operationalize MAMI in Kenya for IRC in our programs. And the key focus was in the refugee operations because that is where we have a lot of, let me use the word control. And initially, what was done is we, through the technical advisors' support, capacity building was done where 15 staff were trained in 2023. And this included a multi-sectoral sort of team where we had the nutrition, clinical services team, and the mental health team, and as well as community service team brought together and trained on MAMI. Then this was now cascaded down to the field operations, where in Hagadera, 33 frontline workers have been sensitized on MAMI and trained, and while in Kakuma, 32 staff have been trained. And this has also gone down to the community health level, where 65 have been trained and sensitized on MAMI, and then 13 lead mothers. These are the mothers that support the mother-to-mother support groups in Kakuma. Another approach has been the CMEs, the continuous medical sensitizations that take place. So MAMI has been incorporated in those sessions for both locations. And yeah, this has been a good approach in terms of bringing everyone to the forefront in terms of understanding what we are trying to achieve. Another key thing has been the tools adoption. So we had during the training, the staff were able to be well sensitized on the tools. And now we have provided these screening tools, monitoring checklist, as well as the follow-up tools. And at this point, I just wanted to bring in Sharon to just speak a little bit in terms of the tools that we are using and maybe a reflection in terms of the tools.
Thank you, Janet. In terms of the MAMI tools that we are currently using, we adopted the global MAMI tools, which is also being used by MOH and have been incorporated in the IMAM participant manual. For assessment, we are using the MAMI assessment tool and the feeding assessment tool. And for enrollments, we are still using the MAMI enrollment forms. Currently, we do not have any registers. For the community screening, we also do not have rapid screening tool. So it's something that we are trying to focus on and at least develop a simplified rapid screening tool for the CHPs. Over to you, Janet.
Thank you. Then finally, in terms of how we have operationalized it in our programming is ensuring that we are raising awareness among mothers through the community health strategy. So we have been, we've made a lot of inroads as IRC Kenya to beef up and align our community health strategy to the MOH guidance. And this is being seen as a pivotal, opportunity for us to ensure that we are scaling up the screening and the referrals for these at-risk mothers and infants. Next. So I think what is interesting for IRC Kenya is the approach we took in terms of implementing MAMI. We did not implement it as a standalone project. We fully integrated it within our health systems. And as mentioned earlier in the first slide, since we are operating in health facilities where we are giving, a variety of services, we saw best to integrate it into our service delivery points. So what does this look like? It looks like community health promoters and lead mothers being able to identify at-risk cases. Then also at our facilities, we have nutrition assistants, and in some cases we have triage nurses, and they are able to, identify and also refer these cases that are during triage and also in the maternity wards through performing, screening. Then we were able in our maternity case, in our maternities also, we're able to identify through the nurses there, the midwives, cases of low birth weight, breastfeeding difficulties, and maternal mental health issues identified, and these are now captured and referred to, the nutritionists who are not always in these service delivery points, as well as mental health officers who are within our facilities but are not always engaged within these points. Then we have also been able to expand our stabilization center services to be able to provide and treat malnourished children under 6 months. And then for the reproductive and maternal health, we have been able to ensure that those children who are identified from this point, they are followed up for 6 months until when they are now supposed to start complementary feeding. Next slide. Another key strategy that we have employed is the fact that it is not a nutrition only intervention, and we are having a multidisciplinary approach where for the nutrition services, for those children who we see, are at risk and they have key challenges on top of ensuring that we are supporting exclusive breastfeeding. For some cases, we offer specialized feeding support and continued, growth monitoring. In addition, we have a mental health team who have also been trained and other sensitized. So these are able to counsel the mothers when it is identified that it is issues that are impacting their mental health that are putting them at risk, and also engage them through support groups and improve on their mental health. Also, we have the community support through the community health strategy, where we are providing outreach and education through the community health promoters. And critically, we also tried to link some of our mothers who had been identified to need extra support with our women protection and empowerment program, who offer some livelihood trainings. And I think Sharon is going to speak to that later. Despite, the noble efforts, we had some challenges there. And then definitely the health services, some of these concerns where these infants and mothers are having issues, health-related, medical-related. So we ensure that this support is able to be given. So yeah, so this is an approach that is entrenched through the health system and not just a nutrition only intervention. Next slide, please. Yeah, so unfortunately, we don't have our mental health support team here today, but these are some of the things that they are doing. They do psychoeducation, so they are teaching mothers about mental health and child development through various models. Then also stress management. These are the mothers who now are identified to have specific issues that are impacting on how they are caring for their infants or also themselves. So they are given techniques to cope with difficult living conditions, which are quite inherent within the, the camp setup. And right now, with all the changes that are taking place, these are really key area of concern. Then there's one-to-one maternal counseling. So for mothers who are experiencing distress, these are supported through the mental health clinics. Next slide. Yeah, so I want to now hand over to the team because they have been implementing in different contexts. Hagadera is different from Kakuma, despite two of them being, camp settings, and also a non-refugee context in Lodwar in Turkana County is also very different. And as you've noticed, I've not really given much information on Turkana. So there are specific challenges in those non-refugee contexts. So Sharon is going to take you through the Hagadera reflections, and then she'll hand over to Vincent for the Kakuma reflections, and then over to Noelyne if she has joined, and then we'll wrap up with the overview of our reflections on MAMI within our programming. Over to you, Sharon.
Thank you so much, Janet. Once again, my name is Sharon Chepkorir. I am based in Hagadera, and I will be sharing our reflections on MAMI implementation in Hagadera. We use a system strengthening approach, focusing on improving identification, management, and support of at-risk infants and mothers. So it's not a vertical program, but it's integrated within the health system. So these are key reflections on what our successes have been. And one is we have seen improved case identification at facility level by having centralized triaging and growth monitoring and promotion for all under fives. So the GMP service point is the first contact point for all the under fives coming to the facility. And we've been able to identify all at-risk infants and be able to timely intervene. And also we have the qualified nurse conducting this growth promotion and monitoring, so we are able to ensure that there are no missed opportunities, even in this service delivery points. The second success would also is better linkages. Initially, when we started implementing MAMI, we didn't have a proper referral pathway. And so children discharged from the stabilization center or at the maternity were being lost at the community level. And so right now, with continued sensitization of health workers, we have seen better linkages. And in maternity wards, we have the low birth weight, the preterm babies, and also the adolescent mothers being linked to the outpatient facilities. And we are able to ensure continued care. Same to also children under 6 discharged from the stabilization center or the pediatric wards. We are able to link with the outpatient and ensure continued care. Another success we would say would be the sensitization of all healthcare workers. The modality we have been using is the continuous medical education that we have been having regularly with the healthcare workers, coupled with continuous on-job mentorship, just to ensure there is standardized care, and also there is improved quality of care to the infants and the mothers enrolled in the MAMI program. Another key success would be improved documentation of MAMI program. Again, when we first started, we had not really agreed on what tools to use. And so it was quite difficult to be able to track. But right now, I'm happy to report that we have improved documentation and even standardized M&D tools, which of course we adopted from the Global MAMI, Save the Children, and MOH. So these have really helped us in tracking the program performance and adapt accordingly. Lastly, I would also mention is the MHPSS assessment and support, specifically at the stabilization center. So what we've been able to manage to do is being able to assess all caregivers of children or infants under 6 months admitted at the stabilization center. I would give like statistics for last year. Out of the total admissions, we had around 68. We were able to identify around 7 mothers who had mild to moderate depression, and we were able to initiate them on care, and they are doing quite well. So integrating MHPSS assessment and support within the SC services has really helped us in identifying at-risk mothers as well. Next slide, please. Yeah, We've also had challenges with the implementation of MAMI. One is the high staff turnover, and this since 2023 till now, we are experiencing high staff turnover, and this is of course affecting our MAMI implementation. We've also had challenges with laws to follow up at community after enrollment. So for Hagadera refugee camp, this context is a bit different in that we have 4 other camps, and we have high mobility within the 3 camps, the four now camps. And the challenge that we've been having is some of the infants we are not able to trace in the community. So this has been a challenge, but we are trying to see how we can address this with the community health promoters. Third is we had a challenge with the caregivers because we had linked a number of around 20 mothers to the livelihood interventions that one of our programs in IRC, where Women Protection and Empowerment offers. And however, we had a challenge with caregivers unwilling to enroll, and it was because of the competing priorities at the household level. So out of the 20 that we had linked to these skill building activities, only 3 were able to participate till completion. The last one is we've had challenges with funding, which I know is global, and due to this, we've lost a number of mental health staff. And so coverage for the health facilities is affected with 1 staff covering 3 health facilities. So in terms of maternal mental health assessment at outpatient level, this is suboptimal, and it's because we do not have adequate mental health staff to support this process. That is all from my end. Back to you, Janet.
Yes, I'll take it over from you, Sharon, and thank you for that. Yeah, so for Kakuma, we are also happy to share some successes since we started MAMI implementation. One of them being, and this was already mentioned by Janet in her presentation in terms of how we operationalized MAMI within the refugee camp setting. So currently, MAMI is fully integrated into primary healthcare services across health facilities. Initially, when we started, MAMI was viewed as a nutrition-only intervention, but a lot of efforts has gone into capacity building of healthcare or frontline healthcare service providers, and the team are more intentional to identify at-risk infants and mothers right at the triage, and then within the child welfare clinics, and at the maternities. So a lot of effort has gone into ensuring that all infants under 6 months are identified whenever they present at the facility level, and any at risk is identified for further assessment and support. In terms of ensuring continued treatment and care, in the first quarter of this year, 55% of the enrolled clients have transitioned to other programs to continue with treatment. And this is such This is a success that has been contributed to by not only the nutrition team, but the rest of the healthcare service provider, the nurses, the clinical officers who are serving at the facility level. So far, over 50% of our clients are continuing with treatment and follow-up. In terms of the recovery rates, 72% of cases have been discharged within the first quarter of this year. Currently, we have 30 infants who are on follow-up, but so far 38 have fully recovered, and we have community health promoters who continue to follow them up at the household level, just to assess their progress, and if there's any issue that that they need to address or that needs to be referred back to the facility, then we have a team that is dedicated in doing that. We've also stepped up awareness creation at the community level. Our community health promoters are doing a good work in this, and the lead mothers for the mother-to-mother support groups are also supporting in creating awareness so that mothers are aware that their infants can be supported, can be treated at the facility level. And then lastly, we've done a lot of capacity building through, and our approach has been through continuous medical education sessions. We've had a lot of CMEs to build the capacity of the rest of cadres of health service providers who are not trained when a few of us were trained. So we've cascaded the skills to the frontline service providers. And this has really evoked a lot of interest amongst the clinical team. And so there is need to continue with capacity building through CMEs and on-the-job mentorship to ensure that the new staff that we bring on board and those who have not been trained benefit and have the right skills to support these infants. Next slide. Next slide, please. Yeah, so I would like to hand it over to my colleague who is supporting the non-refugee setting. Thank you.
Good afternoon, good morning, good evening to you all. My name is Noelyne Otho, and I support the non-refugee camp, non-refugee context, specifically Turkana County. So for us, we have not had an opportunity to implement MAMI. And some of the reflections which have been a hindrance for the implementation are budgetary constraints. And this is from the donor to the government, not prioritizing MAMI specifically, and the restricted scope in integrating MAMI within the programming that is within Turkana County. Considering most of the activities that we do are emergency response in Turkana County. So this has not been a key priority for also the county government and also donors who are supporting the emergency response. Tied to that also is the budget, staffing challenges. One, we don't have enough qualified staff within the health facilities who are supporting services. We have a huge number of volunteers who might not be committed, even if they're trained, might not be committed in ensuring that we implement MAMI, quality MAMI program. Another one would be the nurses in most health facilities are overwhelmed, serving a huge population, and also having other services to render, such as the expanded program on immunization, NC, and treatment of common ailments, as well as IMAM. So the demand on their services creates a loop for them to overlook counseling of the caregivers who are referred from the community to the health facility. Within Turkana County, we have different programs that support cash and voucher programming. And with the existence of these programs, with one of the implementing partners who was supporting implementation of MAMI, which is Save the Children, there was a lot of expectation that if they go to the health facilities to do referrals, then they would expect a token. So this was a huge hindrance to ensure follow-up and also adequate referral to the health facilities. Another issue was poor referral. There's a significant gap between community referral and health facility attendance, influenced by the distance from the community, or the household to the facility. Turkana is vast with estimated square kilometers of 77,000 and only supported by approximately 300 facilities. So this is not sufficient to support all beneficiaries who would need services. So distance from the household to the health facility creates a restriction in terms of access and hence affecting the coverage. However, we have opportunities that we can leverage on. One being that the county is very open to implement MAMI, which creates an opportunity for us to implement if we have enough resources to do so. And also we can leverage on the fact that the national government has introduced a module on MAMI in the ongoing revision of the IMAM guidelines. So I believe that presents a good ground for us to start implementing the host community and reach the most vulnerable children. So back to you, Janet. Thank you very much. Vincent, you can finalize. Vincent, you're muted.
Sorry for that. Yeah, thank you, Janet. So having walked you through our implementation approach and the key reflections in terms of successes and some challenges that we are facing, these are our key recommendations as now. We've summarized them into 5. And during the plenary session, you'll have an opportunity also to interact with us and we'll be able to share a lot more. But generally, we recommend grouping of interventions. So in terms of optimizing the resources that we have, the community health promoters that we have in our settings, we need to align MAMI appointments with child immunizations to enable the CHPs promote efficient home visits. In Kenyan context, community health promoters are supposed to offer holistic, basic community healthcare services at the household level. And so we are recommending that MAMI should not be looked at as a standalone intervention, but it should be part of child health interventions so that when we are tasking the community health promoters to do follow-ups at the household level, then we also expect them to support MAMI interventions. And then again, within the refugee settings, especially in Kakuma, we've digitized our healthcare services. And so again, Kenyan government has also recommended digitization of community health reporting system. So there is need to ensure data elements for referral and management of under 6 months, which are not currently digitized, is incorporated into both EMR and electronic community health information system. Again, during our presentation, we mentioned that we've had challenges with mental health staff because of budget constraints. There is need to train nutritionists and other clinical staff on maternal mental health, because there's huge needs of maternal health within our settings. And so in the event that we don't have adequate mental health experts, then the team who has been trained can continue to offer MHPSS interventions. And then we also need to strengthen community linkages. There is need to invest in the community health services. Because of issues around funding, we've seen our community health services being impacted on negatively, but we really need to ensure we have adequate workforce who are fully equipped with the kits and reporting tools to be able to do effective screening, referral, and post-discharge follow-up at the community level. We also need to build stronger connections with other actors supporting livelihoods programs to address underlying determinants of malnutrition at the household level. So we need to collaborate with the livelihood actors within the camp and within the host setting to ensure that the key drivers of malnutrition are addressed at the household level. But generally, we need to leverage on the ongoing revision of Kenyan IMAM guidelines to ensure that MAMI is fully covered, so that we have an approved reference technical document for everyone to work with while offering services. We are also represented at MOH national coordination meetings. There is need for a lot of advocacy to ensure ownership of MAMI. Currently, there are discussions to transition healthcare services in camp settings to the government. So we need to ensure that the government officials, both at the national and county level, are brought on board to own MAMI fully. Thank you.